Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 333 of our pharmacotherapy series, which majors in diabetes mellitus. The first question reads, JMK is a frail, 82-year-old, unresponsive man who is brought to the emergency department. According to JMK's family, he has become increasingly confused, dizzy, and lethargic, with a recent weight loss of 10 pounds. JMK lives by himself and has been generally healthy with the exception of mild to moderate chronic obstructive pulmonary disease and arthritis. Fasting serum chemistry reveals the following: sodium of 128 milliequivalents per liter, glucose of 798 milligrams per deciliter, serum osmolality of 374 milliosms per liter. The normal range is 280 to 295 milliosms per liter. Blood pH of 7.5. and bicarbonate of 22. His serum is negative for ketones. On physical examination, JMK has poor skin turgor and dry mucous membranes, and is responsive only to deep pain. His BP is 90 systolic 60 diastolic with a pulse of 96 beats per minute. He has RALs at the left lower base of his lung, and a chest radiograph confirms pneumonia. Despite aggressive fluid replacement, JMK's blood glucose remains consistently greater than 250 mg per deciliter and his A1C is 11%. JMK presents with very high glucose concentrations, but has no history of diabetes mellitus. What special factors contribute to a late and atypical presentation of diabetes mellitus in the elderly? Diabetes in the elderly commonly is underdiagnosed and undertreated because it often presents atypically. Classic symptoms associated with diabetes mellitus may be masked by other illnesses, entirely absent, or explained away by the normal aging process. For example, polyuria is minimized by higher renal thresholds for glucose, or it may be confounded by urinary incontinence or prostate problems. Thirst is commonly blunted in elderly persons, increasing their risk of dehydration and electrolyte imbalance. Hunger can be altered by medications or depression. Fatigue often is discounted as part of getting old, and weight loss, although sometimes profound, may be so gradual that it goes unnoticed for months to years. The next question reads, JMK is diagnosed with hyperosmolar hyperglycemic state, abbreviated as HHS. Why are the elderly predisposed to this condition, and what signs and symptoms are consistent with this diagnosis? Hyperosmolar hyperglycemic state is a condition characterized by extremely elevated plasma glucose concentrations, that is above 600 mg per milliliter, and high serum osmolality, that is above 320 milliosmoles per liter, without ketoacidosis. Because patients with type 2 diabetes mellitus have some residual insulin production, they are usually protected against excessive lipolysis and ketone production. Patients with type 2 diabetes mellitus may exhibit hyperosmolar hypoglycemic state in later stages of diabetes as loss of beta cells becomes advanced and residual insulin production continues to drop. Measurements of serum ketones and blood pH differentiate this condition from diabetic ketoacidosis. The condition occurs when urinary fluid and electrolyte losses secondary to glucosuria are inadequately replaced by oral fluid intake. Hyperosmolar hypoglycemic state primarily occurs in the elderly because several factors predispose this population to hypodipsia. These include an inability to recognize thirst, an inability to ask for fluids e.g., dementia, sedation, or intubation, and an inability to get fluids on demand e.g., physical disabilities or restraints. Infections or other acute illnesses e.g., myocardial infarction, GI bleeding, or pancreatitis that exacerbate diabetes can interact with the hyperosmolar diuresis and hypodipsia to produce severe dehydration and hyperglycemia. Drugs that increase plasma glucose concentrations e.g., glucocorticoids, increase diuresis, or decrease mentation also can contribute to this unfortunate situation. JMK presents with several symptoms of hyperosmolar hypoglycemic state dehydration, including osmolality greater than 320 milliosmoles per liter, plasma glucose greater than 600 milligrams per deciliter, pH above 7.3, elevated bicarbonate, decreased skin turgor, hypotension, and the absence of serum ketones. His pneumonia was probably the precipitating factor. Treatment involves rapid IV hydration. Fluid replacement is provided in the same manner as with diabetic ketoacidosis. Insulin infusion is given simultaneously. The initiation and rate adjustments are the same as with diabetic ketoacidosis except that the plasma glucose cutoff to reduce the insulin infusion rate is 300 mg per deciliter, not 200 mg per deciliter as with diabetic ketoacidosis. Rehydration and insulin administration corrected JMK's metabolic imbalance, allowing his diabetes control to be addressed. The next question reads, what are the goals of therapy for JMK? It is widely recognized that strict glycemic control is associated with an increased incidence of hypoglycemia. In the elderly patient with age-related autonomic dysfunction and cardiovascular disease, hypoglycemia may present without the usual premonitory symptoms and can result in severe adverse effects such as angina, seizures, stroke, or myocardial infarction. Therefore, the general tendency when treating elderly diabetic patients is to aim for slightly less aggressive glycemic goals. Thus, a fasting plasma glucose target of between 100 and 140 mg per deciliter with postprandial glucose values less than 180 mg per deciliter and an A1C goal of close to 8%, while avoiding hypoglycemia, is appropriate in this frail patient. The next question reads, how should diet and exercise recommendations be modified for elderly diabetic patients such as JMK? Let's begin with nutrition. The ADA recommends individualized medical nutrition therapy abbreviated as MNT for all patients with diabetes mellitus. The dietary approaches to stop hypertension abbreviated as DASH diet and Mediterranean diets have been shown to be effective for glycemic control and lowering cardiovascular disease risk. Because most elderly patients have type 2 diabetes mellitus, nutrition and exercise programs are the initial steps in therapy. Older people with diabetes, especially those in a long-term care facility, have a tendency to be underweight rather than overweight. Therefore, caution should be used when considering a weight loss diet because this could cause malnutrition or dehydration. For obese individuals, a modest weight loss of 5% to 10% may be indicated. However, an involuntary weight gain or loss of more than 10 pounds or 10% of body weight in less than 6 months should be carefully assessed. Several factors can adversely affect proper nutrition in the elderly. They include an impaired ability to shop for and prepare food, limited finances, an age-related decline in taste perceptions, and coexisting illnesses. Ill-fitting dentures, difficulty in chewing and swallowing, and lack of companionship during meals also can contribute to malnutrition as well. High-fiber diets may lower blood glucose and improve plasma lipids. However, high-fiber diets in frail, elderly patients, particularly those who are bedridden, should be used cautiously because they can be constipating and result in fecal impaction. Ambulatory patients, on the other hand, generally benefit from increased dietary fiber. Because many elderly patients are malnourished, a daily multivitamin preparation containing the recommended daily allowance of each vitamin should be prescribed. Next we will discuss exercise. Exercise in the elderly provides all the benefits derived by younger individuals. It increases well-being and glucose stability, and may decrease a propensity to fall. Exercise also improves BP, the lipid profile, hypercoagulability, and bone density. Physical activity is necessary to minimize any lean body mass loss that can occur with caloric restriction. For patients with arthritis, aquatic exercise may be substituted. Before such an exercise program is initiated, careful evaluation is mandatory to avoid myocardial ischemia or the acceleration of retinopathy. The next question reads, why is it important to institute drug therapy to treat JMK's diabetes? What considerations should be made in selecting an initial treatment regimen? As in all patients with diabetes mellitus, poor glycemic control increases the risk of long-term complications. Although it is tempting to minimize the importance of glycemic control because these complications take so long to develop, patients such as JMK may have had unrecognized hyperglycemia for many years before clinical diagnosis. Thus, many have already begun to develop complications. Furthermore, as life expectancy increases, one can expect that these individuals will live long enough to experience morbidity related to diabetes if they are not treated. Therefore, pharmacologic treatment should be considered in JMK. The general approach to treating an elderly patient with type 2 diabetes mellitus is basically the same as described in a previous case. The initial choice of an antidiabetic agent should be based on the severity of hyperglycemia. Other considerations include body weight, coexisting diseases, and cost of the agent. Patients with impaired fasting glucose, that is fasting plasma glucose above 100, but less than 126 mg per deciliter, should be treated with diet and exercise tailored to their individual capabilities. For patients with type 2 diabetes mellitus, acarbose, a short-acting insulin secretagogue, e.g., nuteglanide or repaglanide, pioglitazone, and a dipeptidyl peptidase 4 inhibitor are all appropriate options. Sulfonylurea-induced hypoglycemia is a concern in these patients. However, if inability to adhere to the multiple daily regimen is problematic, a short-acting sulfonylurea is an appropriate alternative agent. In JMK's case, metformin should probably be used in caution because he has chronic obstructive pulmonary disease increasing the risk of hypoxia. Also, he is older than 80 years of age and requires an assessment of his GFR, which is likely diminished. The favorable effect metformin has on weight is irrelevant in JMK. Thus, although the efficacy of metformin is comparable to that of sulfonylureas, it is not the agent of first choice for elderly patients such as JMK patients with an fasting plasma glucose greater than 300 mg per deciliter, and no overt stress should be considered insulin deficient and started on insulin therapy. The next question reads, LSK is a 53-year-old, obese man with an 8-year history of type 2 diabetes mellitus. His current problems include a BP of 155 systolic 103 diastolic, documented on 2 occasions, blurry vision, and impotence, which he now admits has troubled him for the last few years. Physical examination reveals decreased pedal pulses bilaterally, loss of sensation to monofilament testing, and evidence of an amputated toe on the right foot. His laboratory values are as follows. Fasting plasma glucose of 170 mg per deciliter. A1C of 7.8%. Total cholesterol of 240 mg per deciliter. Triglycerides of 160 mg per deciliter. LSK has normal electrolyte values and albuminuria, that is 180 mg per gram creatinine. His only medication is metformin 500 mg orally twice daily. Describe the pathogenesis of hypertension in patients such as LSK. Why is it so important to treat his hypertension? 75% of adults with diabetes report having a BP of 130 systolic 80 diastolic or more, or use medications for hypertension. Hypertension in type 1 diabetes mellitus is usually of renal parenchymal origin and occurs 1 to 2 years after the onset of nephropathy as indicated by albuminuria. The relationship between type 2 diabetes mellitus and hypertension is more complex and not as closely correlated to nephropathy. In type 2 diabetes mellitus, hypertension is often part of the metabolic syndrome and may be present for years before diabetes is actually detectable. Patients with diabetes mellitus and hypertension have an increased risk for experiencing microvascular complications such as retinopathy and nephropathy. They are also at a twofold increased risk of having cardiovascular disease. A 5 mm of mercury reduction in mean diastolic BP can produce a 37% reduction in microvascular complications, and a 10 mm of mercury reduction in mean systolic BP had previously been found to reduce the risk of myocardial infarction by 11% and death related to diabetes by 15%. However, because lower BP targets are tested, the benefits are becoming less clear. In the Accord blood pressure study, the intensive control arm achieved systolic BP of 119 mm of mercury, did not reduce total cardiovascular events, non-fatal myocardial infarction, non-fatal stroke or death from cardiovascular causes compared with standard therapy, achieved systolic BP of less than 133 mm of mercury. However, microvascular benefits were observed, as was a statistically significant reduction in stroke. Therefore, the existing ADA BP goal of less than 140 systolic 90 diastolic is reasonable, and lower goals should not be targeted in practice unless it can be done without adverse effects. Treatment includes weight management, exercise, sodium restriction, to less than 1,500 mg per day, smoking cessation, and antihypertensive therapy. LSK should be started on an angiotensin-converting enzyme inhibitor. Angiotensin-converting enzyme inhibitors have traditionally been available as less expensive generics, although angiotensin receptor 2 blockers are also available and appropriate. Many patients require 2 or 3 medications to achieve the target BP goal of less than 140 systolic 90 diastolic. The next question reads, what is the significance of the presence of albumin in LSK's urine? How should it be managed? Diabetes is the leading cause of end-stage renal disease and accounted for 44% of new cases of renal failure in 2005. Diabetic nephropathy is characterized by nephrotic syndrome and azotemia. It is a major cause of death in patients with type 1 diabetes mellitus and is an increasing source of morbidity in type 2 diabetic individuals. Thickening of the glomerular capillary basement membranes is the hallmark of diabetic nephropathy. Diffuse deposition of basement membrane-like material expands the mesangium. This process narrows the capillary lumina, impedes blood flow, and thereby reduces the filtering surface area in the glomerulus. Hyperglycemia causes intraglomerular hypertension and renal hyperfiltration. Hyperfiltration is followed by albuminuria with minimal glomerulosclerosis, which still is potentially reversible. If left untreated, overt proteinuria occurs, and the patient usually progresses to nephrotic syndrome. Progression of diabetic renal disease can be accelerated in the presence of hypertension, proteinuria, and diabetic retinopathy. Lipid abnormalities also may contribute to the progression of glomerulosclerosis. Management includes early detection through screening for albuminuria, tight glucose control, use of ACE inhibitors and angiotensin receptor 2 blockers for patients with albuminuria to slow progression, aggressive management of hypertension that includes an ACE inhibitor or angiotensin receptor 2 blocker as first-line therapy, aggressive management of dyslipidemia, and smoking cessation. Regarding screening for and confirmation of albuminuria, the preferred method of screening for albuminuria is measurement of the albumin to creatinine ratio in a random spot collection, preferably the first void or morning sample. Albuminuria is defined as a urinary albumin excretion of 30 microgram or more per milligram of creatinine, or mg albumin per gram creatinine, during a spot collection. Because of day-to-day variability in albumin excretion, 2 of 3 urine samples collected in a 3 to 6 month period need to be abnormal before a designation is made. Annual screening should be performed in patients with type 1 diabetes mellitus with a duration of at least 5 years and in patients with type 2 diabetes mellitus from the time of diagnosis. More frequent screening is indicated if hypertension, any increase in serum creatinine, or retinopathy develops. Urine albumin concentrations can be falsely elevated over true baseline values by exercise within 24 hours, fever, infection, uncontrolled diabetes, uncontrolled hypertension, and heart failure. On the basis of established criteria, LSK has albuminuria 180 mg albumin per gram creatinine. Management includes tight blood glucose control and an ACE inhibitor or angiotensin receptor 2 blocker should be started. LSK should already be receiving one of these agents to treat his hypertension as noted. After initiation of therapy, continued periodic monitoring of the albuminuria is recommended to assess the response to therapy and progression of disease. Serum potassium and creatinine levels should be followed as well. The next question reads, LSK is treated with lisinopril 20 mg per day, which controls his BP and improves his albuminuria. His dose of metformin is titrated to 1000 mg twice daily. Recent laboratory values include an fasting plasma glucose of 130 mg per deciliter, A1C of 6%, triglyceride level of 170 mg per deciliter, total cholesterol of 204 mg per deciliter, LDL cholesterol of 135 mg per deciliter, and HDL cholesterol of 35 mg per deciliter. How does the risk of heart disease for patients such as LSK compare with that for persons without diabetes mellitus? What is the pathogenesis of coronary heart disease in persons with diabetes mellitus? Coronary heart disease is the leading cause of premature death in the type 2 population and accounts for 50% of the deaths in people with diabetes. Relative to non-diabetic individuals, those with diabetes mellitus are 2 to 3 times more likely to develop coronary heart disease, and their risk of death after an myocardial infarction also is 2 to 3 times higher than the non-diabetic counterparts. Women with diabetes, regardless of their age or menopausal status, have equal risk for coronary heart disease to that of non-diabetic men. These sobering figures point to the importance of minimizing or eliminating all other preventable risk factors for cardiovascular disease in patients with diabetes, i.e., tobacco use, hypertension, hypercholesterolemia, obesity, through the prescription of exercise, diet, and appropriate medications. We will now discuss the pathogenesis. The pathogenesis of cardiovascular disease in people with diabetes is complex. The metabolic syndrome with its attendant cardiovascular risk factors, dyslipidemia, inflammation, and hemostatic abnormalities are only some of the mechanisms under study. The most common lipid abnormality in type 2 diabetes mellitus is hypertriglyceridemia, that is above 150 mg per deciliter, with low levels of HDL cholesterol, that is below 40 mg per deciliter in men or below 50 mg per deciliter in women, similar to the lipid profile seen in LSK. Poor control of type 1 diabetes mellitus also is associated with low levels of HDL cholesterol and a smaller, more dense LDL particle. These lipid abnormalities, along with a greater prevalence of hypertension, contribute to the risk for cardiovascular disease. In patients with diabetes, clinical trials of lipid-lowering therapy, primarily with statins, have demonstrated primary and secondary coronary heart disease prevention. Although the evidence for the reduction in hard cardiovascular disease outcomes, e.g., coronary heart disease death and non-fatal myocardial infarction, is stronger in diabetic patients who have a high baseline cardiovascular disease risk, i.e., known cardiovascular disease or very high LDL cholesterol levels, the overall benefits of statins in patients with diabetes at moderate or high risk for cardiovascular disease are convincing. Readers are referred to the ADA Standards of Medical Care for more detailed information on the cardiovascular disease clinical trials in patients with diabetes. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 334.